Let's talk a little bit about some of these risk reduction tools. An age-old problem for surgeons is that of informed consent, or what patients claim is a lack of informed consent. So we studied that to try to understand why is it that surgeons lose or feel as if they're going to lose an informed consent case. And here's what we found out. First, patients would often say, I just signed a bunch of papers. I just signed a bunch of documents. I couldn't tell you how many or what they said. The informed consent document is a very important patient education tool. So perhaps we need to treat that document differently. So what we're suggesting is what we call the second generation informed consent form, which incorporates certain strategies. Based on what patients are saying, I don't know what I'm signing. Here's the first strategy. Let's put in an introductory paragraph. And that introductory paragraph will basically say, do not sign this form. Don't sign it. Don't sign it until you understand the risks, alternatives, and all of your questions have been answered. Now we might word that more nicely, but essentially that's what it's going to say. It's going to set the table, essentially getting the patient, because they're going to sign that first paragraph, getting the patient to say, you know what? I confirm that this is an important document. And I'm not going to sign this document unless I understand that there's risks, alternatives, and unless my questions are answered. Second strategy. It's time, and not just for bariatric and general surgery, but many would argue, including me, for all specialties to have a specialty-specific informed consent form. So for bariatric surgery, for other types of general surgery, put the risks right in the form. The generic form doesn't help us, has never helped us, and it's maybe why so many surgeons feel as if informed consent's not that worthwhile. You might be right, but you're only right with the old form. With the second generation form that has the risks right in it, it in fact is going to help. That's the second strategy. Third, there's three things that informed consent cases are about. Number one, patients saying, I didn't read the form. Number two, they read it, but they say, I didn't understand it. It had a lot of words I didn't understand. Perhaps I can't even read. And so they say, I read it, but I didn't understand it. Third, they say, he or she, speaking of their surgeon, they ran out before I could ask all my questions. I had questions, a lot of questions, and they wouldn't answer them. That's what these cases are about. So what we're going to do is we're going to change the job of the witness. The witness, old school, used to witness the signature. So they're witnessing that your patient's signature is their signature. But none of the cases are about that. So what we're going to have your witness do is ask three questions. Did you read the form? Yes, no. We're going to put it right on the form. Do you understand the form? Yes, no. Do you have any questions? Yes, no. And pursuant to a practice or a policy, the witness is only going to sign the form when they get yes, yes, no. So they've now confirmed, and it's good for patients, they've confirmed that the patient read this very important educational form, that they understand what it says, and that they have no questions. It's a patient-focused tool, and yet it's one that goes a long way towards reducing the possibility of a lack of informed consent case. We have probably 100, 150 practices, more than that, around the country that have been using this. Hundreds of hospitals around the country have changed these forms. If your hospital doesn't want to change its form, we have surgeons that have a second form that they use that's generated from their office. So second generation informed consent. If I say that and you sort of think to yourself, I don't know what that means, then you better get more information about it because it's a great risk reduction tool.